something that's very near and dear to my heart. I also am going to talk a little bit about the specific kind of patient factors or personal factors that can end up being risk factors for experiencing medical trauma, especially for those who've been deployed and who've had exposure to burn pits. And then last, I want to talk briefly about a few assessment tools. They're connected with my book, but also I share with researchers and practitioners in hopes that they can be helpful in the clinical setting, whether that's the healthcare setting or the mental health treatment room. So I want to start out by first just looking at what is medical trauma. When I first started doing this research, a couple of decades ago almost, what I would find is when researching medical trauma is really the term didn't exist. What I would find is a lot of information about trauma medicine. So the idea was that trauma is something that happens outside of the healthcare setting, and you go within the healthcare setting in order to be healed. I did find a little bit about medical trauma, specifically working with pediatrics, but nothing in terms of working with adults, and certainly really not anything out there related to some of the experiences that I had endured. So what I did find about medical trauma, though, was quite focused on the patient and risk factors. So this idea that a patient coming in, if he or she were to experience trauma related to the medical setting, then this is somehow maybe a weakness or a predisposition, but really had nothing to do with the healthcare setting itself. And my experience was very different. And so I worked very hard to attempt to articulate and kind of put into practice some of my own experience. And I'm really kind of coming at my understanding of medical trauma through more of an ecological lens, very contextual lens. So in this case, my definition for medical trauma is that it is a trauma that occurs from direct contact with the medical setting. That can be, pretty broad in terms of illness, diagnoses, treatment, stays in the hospital. But that develops through a complex interaction between the patient and some of those risk factors, the medical staff and the communication and the relational experience between patients and staff, the medical environment itself, which certainly can add to the stress that patients feel. And then also their specific diagnostic and procedural experience. So the actual medical interventions they experience, the experience of living with, let's say, chronic illness, and we'll talk about that specifically related to burn pits. And these can have a powerful psychological impact for the patient, and I would say the patients, also for family members of patients, and even the medical staff who are working with patients. And these impacts, really kind of come about in part due to that particular patient's unique interpretation of the event itself, or the series of events, I should say. And so just to look kind of graphically at the ecological model, I think of this as kind of nested systems in a sense, with, of course, the patient being in the center and our focus on the patient using kind of trauma-informed and patient-centered care. But, kind of beyond that, there's the patient's experience of the procedures or the illness, the interventions that are required to help them in the treatment of that illness. And then beyond that is the communication between the patient in their kind of treatment experience with the medical staff. And, for all of us who've been connected with healthcare in some way or another, we've likely all experienced at least one episode of care in which we would say the communication was problematic and maybe led to some mistrust or increased feelings of vulnerability, even fear, or a lack of belief in that medical, personnel's ability to help us. Lack of compassion as well. And then all of this is existing in this final kind of sphere or context, which is the medical environment itself. And as we know from having gone to hospitals and specialty care kind of centers, going in for procedures, that often the medical environment is not the most conducive to comfort, for sure, and certainly can be a trigger of a traumatic stress response. So I want to talk a little bit about medical trauma in terms of the experience of the patient or the person who is experiencing that trauma. And first and foremost, I would say that it is based on the subjective experience of the patient. Some early research that I consumed in my work, again, was very much focused on, first and foremost, that if a trauma occurred in the medical setting, it is because of some deficit or weakness or vulnerability in the patient. And also some early research really kind of demonstrated that the only way you could experience trauma in the medical setting is if you experienced a objective traumatic experience, life-threatening, chaotic kind of experience. And my feeling is, if a patient experiences their diagnosis, their illness, their medical, intervention as traumatic, then it is trauma. Bottom line. So we really need to kind of stay focused on the patient and his or her experience. Also, I would say medical trauma could be understood on a continuum. This is not something that solely happens in the hospital setting, in the emergency department, in these life-threatening medical issues. This can happen anywhere. Someone who's experienced medical trauma in the past, hopefully they're going to continue to show up for primary care and even secondary care for chronic illness. And when we think about that, this person has been previously traumatized and is coming back into a setting that's a lower acuity, maybe the primary care setting, but is still kind of holding that kind of memory and that experience of trauma in their bodies, as well as kind of affecting their thoughts and feelings about being in the medical setting. So that's another important point. Also, I would say medical trauma is not just something that's kind of that affects people psychologically, but in fact, this is a holistic experience for people in terms of knowing how trauma affects the body and stays with the body. And certainly psychological, emotional impacts of medical trauma, but also social impacts. And often people who've experienced medical trauma, they go back into their context, whether we're talking about their family, their relationships, work, and it certainly can affect the quality of those relationships and have a ripple effect in their lives. And lastly, I would say that medical trauma can be quite a spiritual experience, especially for people who fear for their own lives, can bring up a lot of existential questions and challenges for them. Certainly, medical trauma is contextual. Again, we're not focused solely on the patient and what's happening in his or her mind and body. It doesn't exist in a vacuum. It exists in a complex context in the medical setting and with others who are, there on behalf of patients to help them. Something else that's I think quite unique in terms of trauma, especially medical trauma, is the relational aspect of medical trauma. When patients experience trauma within the healthcare setting, they are experiencing this within the context of the relationships with their providers, with their doctors, with their nurses. And that's a very complex relationship, especially when we're not feeling safe and we're potentially feeling trauma from specific interventions, from the environment around us, when we are kind of activated, when our bodies are activated, and we have this relationship with a provider who's ostensibly there to help us and to heal us, but who is simultaneously enacting, interventions and procedures that cause us a significant amount of pain, distress. That's a very difficult kind of double bind to work through sometimes for patients. And then last, that medical trauma is complex, in part because this is often a disenfranchised kind of experience and kind of trauma that in many ways, medical trauma is something that remains unidentified, certainly unacknowledged. We don't do a lot of assessing for medical trauma, broadly speaking. And so oftentimes patients are suffering in silence and often don't connect their emotional experience and their psychological experience, both within the medical setting and then upon discharge, going back into their lives. They don't connect that often with what happened to them in the medical setting. So something to kind of keep in mind, and really connects with burn pit exposure, because in part, we're seeing survivors of burn pit exposure who've experienced significant healthcare implications. And this has often been quite invalidated on a massive and systemic scale for them. And so, once they're developing some of these illnesses, very, serious illnesses and long-term illnesses, and going into the medical setting, they've, likely experienced a sense of mistrust already. And, in looking at kind of the power differential, the powers that be, in terms of the military, in terms of the VA, being kind of invalidated for their experience, and certainly for the connection between their medical diagnoses and their exposure to burn pits. So something that creates kind of a risk factor for military and veterans who were exposed to burn pits. And so in looking at the medical diagnoses associated with burn pit exposure, again, as Victoria mentioned, there's so much in the news, and has been for quite a while, in terms of burn pit exposure. But in specifically speaking, when we look at the presumptive conditions, the first to kind of come out and be officially recognized and sanctioned as conditions tied to burn pit, we're looking at respiratory illnesses, asthma, sinusitis, rhinitis. And as we know, within the context of the pandemic and COVID, respiratory illnesses, difficulty breathing, that most basic human function, that can be terrifying for people, especially as it kind of continues, as we're seeing it develop to more serious respiratory issues. But also some of the conditions linked to burn pit exposure can include COPD, migraines, chronic skin rashes, and autoimmune disorders of many different forms, Parkinson's disease, peripheral neuropathy, lung cancer, pneumonia, emphysema. And I would say not only lung cancer, but they've begun linking several kinds of cancers. And so these are quite serious medical issues and life-threatening, certainly life-altering. And so as things unfold and we start to see more and more of these conditions actually kind of put on that list, that official list of presumptive conditions, then hopefully we will see more benefits and more medical care for those who've been exposed to burn pits. So in looking specifically at the patient, the veterans, active military who've been exposed to burn pits, and their context, their unique context going into the medical setting that can certainly create vulnerabilities for them. The first I wanted to mention is the prevalence of comorbid respiratory diseases and mental health diagnoses at the VA, specifically anxiety, PTSD, and depression. And in one particular study done by Respiratory et al., 182,338 service members who were studied. Of those service members, 77% received concurrent mental health diagnoses. So we're looking at, some comorbidities that are really important to pay attention to, because, prior mental health diagnoses, this is one of the most, I would say, important risk factors for experiencing medical trauma, especially PTSD. And we could have a 3-day session focusing specifically on PTSD and veterans and service members. So that's a big risk factor going into the medical setting. So in the special context of burn pit exposure, we have aspects that can certainly create more vulnerability for our military patients. Certainly the stress of deployment, and a lot of the burn pit stories and experiences that we've read about, certainly in media outlets, are focused on deployments in Iraq, in Afghanistan. And so we can understand the context, at least kind of conceptually, we can understand the context of those experiences, and then add to that being in close proximity for days, weeks, months to burn pits, where over 1,000 different kind of chemical compounds are released in the air, and with jet fuel being used as the propellant for those burn pits. This is a lot in terms of what our military members have experienced. We also have then the next layer, which is the invalidation, that whether a service member has experienced directly, invalidation of their experience, their medical ailments. They've certainly read about it, and it's been everywhere in the news. And so this kind of creates this kind of broad, almost collective invalidation of their experience, certainly in terms of the lack of the governmental response to ensuring that they have benefits. That can lead to really a sense of betrayal and a lack of trust. And when we think about the power differential, certainly within the hierarchy of the military, but then also the power differential going into the medical setting and being treated by a physician, being at the mercy of others in terms of your treatment. When we go in with a lack of trust and a sense of betrayal, that's already going to potentially strain the doctor-patient relationship. So also, when service members have a personal history of trauma or mental health issues, and even looking at the Respiratory study, there's a lot of comorbidity in terms of these respiratory diseases that service members are coming to the VA to be treated for, and mental health diagnoses. Certain personality factors and resiliency. I would say, having worked with active service members and veterans for almost 20 years, these are some of the bravest and most resilient among us. I think we probably would all agree to that. But this resilience has been tested time and time again. And when we consider the context of their work and their deployments, that really takes a toll on a person's ability to then handle the subsequent development of these physical conditions And certainly we want to kind of pay attention in the kind of broader sense of medical trauma to meaning making. What does this all mean? How is this particular patient experiencing what's going on around them? How are they making connections? How do they feel about what's happened to them? How do they feel about getting medical attention? And what is that experience like? And then also, I would say special context includes the experience of what I call secondary crises. So you have the medical trauma experience itself, and then often we see a cascade of other ill effects in their lives. And so some of the costs of medical trauma on mental health, I mean, certainly the specific mental health conditions that can develop as a result of medical trauma, PTSD, anxiety, depression, just a kind of ongoing higher level of stress in the body, but also, grief and loss, loss of abilities, maybe loss of how their life once was. And then we look at the effects, the overall effects on wellness. And these are some of those secondary crises, the domino effect that medical trauma can have. Certainly physical health. And one of the most concerning for me that I see quite often in my practice is medical avoidance. After experiencing medical trauma, invalidation. Some of my clients who suffer with medical trauma talk about and framed it as medical gaslighting. When they're not believed, when the connections between certainly their exposure to burn pits and the subsequent health conditions they experience. Certainly relational health, effects on families, on significant other relationships. This is often something that I see in my work with my clients. And so helping them to reestablish quality and loving relationships, and also to help them begin to feel safe again, safe with others, sometimes safe with themselves, in terms of their body becoming kind of a source of threat for them. Vocational effects certainly can have a ripple effect in their work, maybe what they can do. Many, as we know, many service members and veterans are to the point where they're needing to look at disability benefits. So this loss of ability throughout their lives and their different life domains can certainly have powerful psychological effects for them. Certainly lifestyle, financial stress. Certainly, too, when we think about the numbers of claims that have been denied between 2007 and 2020, vets were often dismissed as, maybe anxious or out of shape, especially with those respiratory issues. Again, that sense of invalidation. And in that time, according to the New York Times, between 2007 and 2020, about 78% of VA claims were denied for treatment related to burn pit exposure. So I think that's pretty astounding. And again, coming back to the financial strain for those who don't have the ability to get those VA benefits and maybe don't have private health insurance. Spirituality, spiritual health can certainly be impacted in terms of medical trauma, especially when we experience life-threatening medical treatments or conditions. And then again, kind of that sense of self and how that changes in terms of our experience in medical trauma and our then experience and how that unfolds in the rest of our lives and with the people around us and in terms of our capabilities. So I wanted to just very briefly mention the assessment tools that I've shared with you and that Pessy will share with you, and hopefully these can be helpful. Many of these skills are being used in research studies around the country at this point, but my ultimate kind of goal for these tools is for them to be helpful clinically, That is my passion, to help my clients and to help others help their clients within mental health. And so the resources are, number one, the Experience of Medical Trauma Scale, which is kind of more of an ecological tool that can be useful in the hospital setting to help patients really identify the factors that are contributing to their overall distress. And also the medical mental health screening, which certainly can be helpful when we're working with clients who are going into the hospital setting for a particular procedure, or they are engaged in specialty care, maybe for our clients who have been diagnosed with cancer or autoimmune disorders, pulmonary diseases, where they're going to need ongoing care. The medical mental health screening really helps us to pinpoint some of the most important risk factors for experiencing medical trauma. And then last, the Secondary 7 lifestyle effects screening tool, which, as in the previous slide I mentioned, the ripple effect that medical trauma can have in the lives of our clients. And so this helps us to pinpoint and start the conversation with them about the different areas of their lives that have been affected, and help them make those connections between their experiences with these different domains of life and their mental health effects, help them connect those to their medical experience and put it into context for them. And so I wanted to kind of wrap up here with talking a little bit more about treatment considerations, especially for working with military and veteran clients who've been exposed to burn pits. Certainly the first is to consider the unique experience of your client's diagnosis and treatment history in terms of their medical history. And as mental health professionals, we do a good job of assessing and kind of getting to know our clients and their functioning in different life domains. But sometimes we get a health history and we don't necessarily ask deeper questions about their experiences within the hospital setting, if they've been kind of stayed in the hospital, or their experiences with chronic illness and the effects that has had. In part because I think most of us, especially as adults, we were socialized to kind of to grin and bear it, in terms of whatever medical interventions need to happen to keep us healthy, to preserve our lives. But we don't often think about the trauma that is inflicted on the body, but also on our psyche as a result of that. So consider the context in which your client became ill. In the case of burn pit exposure, there's a lot to unpack there, in terms of their experience in deployment, their, the trajectory of their illness that, can be linked to their exposure to burn pits, the possible invalidation that they've experienced within the medical setting, or just more broadly in the media, and how that's had an impact for them, in part in experiencing this as kind of a disenfranchised illness. Consider how your client makes meaning of this context, this experience, particularly perspectives about the governmental response to burn pit exposure, the support that they may have received from military, from VA or not, and their experience of medical treatment. So asking the questions to help them make sense of this experience. Really take time to build rapport, which is something that we do anyway. But I really stress this in terms of medical trauma, because more than likely, at least in my experience working with clients, they've experienced significant invalidation, not only from healthcare providers, but also from people closest to them, from family, from people they love and trust, who are saying, you just need to get over this. And kind of, again, that grin and bear it. And so that time establishing rapport and trust is critical, providing validation of your client's experiences as medical trauma. And as we know, there's power in labels. And engaging in the assessment process, helping clients identify the secondary crises as well as the mental health effects, and offering up resources, serving as an advocate. We need advocates in terms of medical trauma, and engage in treatment of specific mental health effects of medical trauma, and helping them to kind of create that linkage and that understanding. So I want to again thank you for listening, and I hope that you continue to explore medical trauma. And there's so much out there in terms of research on helping our military and veterans. There's more and more research coming out specifically about burn pit exposure, but also I would say if you're working with particular clients who suffer from specific ailments, to look there in terms of your research in medical trauma. So respiratory conditions in medical trauma, cancer in medical trauma. There's a lot out there. I tried to pull together a lot of it in my book, but there's so much more that has been done since then. And also I just wanted to share my contact information, because I know we don't have a lot of time for Q&A, but if you have comments, suggestions, if you have questions, you want to link up around these topics, I invite you to send me an email. I'm at flaum@xavier.edu, and I'm also on LinkedIn. So thank you very much. And Victoria, I think I will turn it back to you.
Oh my goodness. Thank you so much for your presentation. You covered so much ground in a short period of time. I feel like we could have several more sessions on this and not cover everything. Yeah. So there have been some questions coming in. Please, everyone, continue to send your questions. And I'll pose them to you, but I know we don't have quite enough time to answer them as fully as you might like to. First, as you've said, medical trauma is disenfranchised trauma. And in fact, this may be the first time some of our audience members have even heard the term. What do you suggest for how people can learn more as they begin to orient themselves around this type of trauma?
Well, I would say, thankfully, since I started doing my work, and as you mentioned, my book was the first to really address medical trauma, and there just wasn't a lot there. And so it was certainly a labor of love, and very frustrating, because there wasn't a lot there. And so I felt like I was pulling together a lot of puzzle pieces. Since then, there has been more empirical research, but also I'm seeing medical trauma more in the news. And like I said at the beginning, even when I started, you didn't see those two words together, medical trauma. So much has happened since then. I would say, first and foremost, to look at some of our trauma organizations, the International Stress and Traumatic Stress Network. Also, interestingly, the National Child Traumatic Stress Network. Even though this is focused on pediatrics, there are some wonderful resources there in terms of working specifically with medical trauma. I would say, just to begin kind of doing some digging, and I have some articles out there in my early work on medical trauma, but certainly there's more and more happening in this realm now. And I would say that that term disenfranchised trauma, it really became something very I guess kind of real to me as I worked with my clients, and time again, I was hearing this invalidation. I was hearing this, this really questioning or completely dismissing their mental health experiences related to their experience with a particular disease or a traumatic event in the hospital. And I also do some work in disenfranchised grief. And so it wasn't much of a leap for me to then think, well, this is a disenfranchised trauma, especially for adults. I would say probably not so much for children, but for adults, I would say this is a disenfranchised trauma.
Mhm, mhm, mhm. And betrayal is such an important layer of this, as you said. So the service member is doing a job that they were assigned to do, and it's wreaked incredible
Yes,
havoc on their lives. And then, like you said, there's the power differential between the medical provider and the patient. Medical treatments themselves may be very intrusive, very uncomfortable.
yes.
Can you give us some tips of how you work with clients who are feeling betrayed and invalidated and who've experienced medical trauma?
Absolutely. So, one of the things I emphasize in the presentation, and I'll say a little bit more about, is that, um, that acknowledging that what they've experienced is medical trauma. I mean, even in using those words, there can be such power in labeling
Mhm.
someone's experience, for them. And I've had clients, even in those first conversations, when I have kind of said, it sounds to me like you've experienced, trauma directly related to what you experienced in the hospital. And I, use that term medical trauma, um, kind of an outpouring of emotion. It's amazing how quickly we can feel seen when we use terminology. There's power in words, and there's a validity of someone's experience, in terms of those words. Then I take a pretty detailed narrative, and really kind of help to support them as they begin to tell their story. Certainly using trauma-informed interventions and helping them to understand the broad scope of their experience with medical trauma. A lot of times people haven't, put kind of two and two together in terms of, the maybe the grief they've experienced, the depression they've experienced, certainly the possibly anxiety or even PTSD that they've experienced, and being able to kind of tie this back. So kind of making those linkages for them using evidence-based trauma-informed interventions. I really stress using holistic mind-body interventions, that be part of your toolkit. When I experienced my medical trauma and developed PTSD, I was a cognitive therapist at the time. And so I mistakenly thought I could think my way out of this. And also I would say sometimes therapists make the worst clients in terms of, we take on too much and we're often stoic. And so it was my thought that, well, I need to figure this out. I need to treat myself.
Mhm.
And, I found mindfulness, I found yoga, I found a lot of mind body interventions, which quickly showed me that, trauma is not something we can think our way out of. As I said, we experience it in the body. And so we need to kind of treat it holistically.
Mhm.
Um, that's really important. I think, some of the assessment tools, hopefully they can be helpful for people in terms of, giving kind of questions, but also kind of helping you to identify kind of the various ways that medical trauma can manifest. That we're not just talking specifically about PTSD, we're talking about kind of a bigger picture here in terms of mental health effects. But I would guess one of the most powerful interventions that I've used with clients, and this is kind of what clients have shared with me, is that very person-centered, validating approach with them, because they're seen, and helping to build that empowerment. I also work to help them build some skills to be able to advocate for themselves within the medical setting. Helping them to in some ways reshape protocols. I have one client I work with medical trauma, and she's a former military, and so experienced quite a bit of trauma in her life, and also medical trauma, medical avoidance. So she stayed kind of away from the medical setting. And this was during COVID. She had a surgery she needed to go to. She really needed her husband with her as a support. And the agency or the clinic said, nope, you can't have anybody back with you.
Mhm.
So, I helped her kind of create a new protocol, wrote a letter to the facility and asked that they change their protocol for this client, who, it made a big difference for her to have support there. So we might be acting as advocates for our clients, helping them to advocate. So much we can do. So hopefully this just, I know it just scratches the surface, as you said, but we, there's so much research yet to be done, and we need lots of advocates, in terms of medical trauma, especially for this population, for our military.
Yes. Yes. So holistic, evidence-based, trauma-informed, person-centered, flexible with advocacy. Perfect. I have just one final question, if I may. There were a bunch of questions in the Q&A about the screening tools.
Yes.
I feel like, again, we can have a separate training on those alone. For folks who couldn't find them, they're located at the end of your handout, and your handout is in the session portal. Can you briefly, Michelle, walk us through how you use these tools in your practice? Are you routinely giving all of them to every client, or what do you recommend?
Yeah, so I would say that the first experience of medical trauma scale, it was developed to be used in the hospital setting. So mental health professionals who work in the hospital, kind of in real time with patients, to help them identify the factors contributing to their distress. But I will say that it can be a really helpful tool, kind of retrospectively, to show to clients and walk them through their medical experience. As they're telling their trauma narrative, they can really pinpoint specific areas of their experience that are just kind of the memories locked in their bodies, that they can say, yes, this was really, really difficult for me. When I, this lack of privacy, and I felt so exposed and vulnerable. Those kinds of things are going to come up when you look at the experience of medical trauma scale. The medical mental health screening I use a lot in terms of prevention. When I have clients who are going into the hospital, or they're going in for any planned procedures, to look at these are the risk factors associated with the potential for developing subsequent a trauma response following experience in the healthcare setting. And so that helps us to pinpoint and then make a plan and help to really formulate our interventions to help our clients prior to going in. And then that last secondary 7, this is to really help our clients pinpoint the different kind of domains of life and how they're seeing maybe some dysfunction or some kind of areas where they're really struggling, and kind of helping kind of to intervene and to target our interventions in those particular domains of life. So this is kind of that ripple effect of medical trauma, and helping us to kind of get our arms around what's happening for our clients.
Yeah. I love that there's a piece in there on prevention too. Michelle, thank you so much for generously sharing those with us and for being here this morning. I learned so much from your presentation, and I'm sure the rest of our audience did as well. We really appreciate you taking time to be here with us.
Thank you so much. It was an honor. Thank you.
So everybody will gather again at 9:15 Central for a presentation by Dr. Bill Brim on understanding military culture. We'll see you over there.